endeavor to keep the members updated with the latest scientific, statutory, and other developments which might have direct or indirect bearing on the field of health hospital administration. And one of the initiatives to that effect is this AHA webinar, which is being organized fortnightly on the first and third Saturday of the month between 3 to 4 p.m., inviting experts on different subjects. And today's topic is disability compliance in healthcare settings, which is a very pertinent topic. According to an estimate, around 1.3 billion people, which means 1 in every 6 of us, experience some or significant disability in our lifetime. Many of our patients and staff members have some form of disability, and many of them have a temporary disability while they are admitted to the hospital. This reinforces the need for ensuring inclusion, accessibility, and non-discriminatory practices in the hospital. The Rights of Persons with Disability Act of 2016 provides a broader framework for the empowerment of persons with disability, and the Ministry of Health and Family Welfare, Government of India, has also issued accessibility standards for healthcare, which are quite comprehensive. CPWD, in fact, has also published a document titled Harmonized Guidelines and Standards for Universal Accessibility in India, which are also very comprehensive. And to discuss all this, today we are very happy to have with us Dr. Satendra Singh. Dr. Singh is a professor of physiology at the University College of Medical Sciences and GTB Hospital. He is also the founder of Health Humanities Group, a visiting scholar at the McLean Center in the University of Chicago, and co-chair of the International Council for Disability Inclusion and Medical Education. He is a disability justice advocate who has brought many policy reforms, including the inclusion of disability rights as disability competencies in the new medical curriculum in India. His research focuses on disability and global health, and his work helps to reduce health disparities for persons with disabilities and ensures that learners with disabilities have fair access to medicine. He is also a member of the core group on disability at the National Human Rights Commission, and advisor to the Court of State Commissioner for Persons with Disability, Government of NCT of Delhi. So thank you very much, Dr. Satendra, for sparing time to deliver today's talk. But before I hand it over to Dr. Singh, I request that you all please keep your microphones muted. If you have any questions, you are welcome to write them in the chat box with your name, and we will take questions at the end of this session. So with that, I invite Dr. Singh to please deliver today's talk. Thank you. Dr. Singh, please unmute.
Good afternoon, everyone. Thank you so much, Dr. Mahesh, for giving me this opportunity to speak to the members of Academy of Hospital Administrators. And thank you so much, President Sharma, for having me on this webinar to sensitize the members on the disability compliance for hospital administrators. The key issue is that we have disability rights, but the problem is we need to make the rights real. And that is why the first thing which comes to the mind is that, first of all, we need to create awareness. So today I'll be talking about some of the, the nitty-gritties of the disability compliance, which should be seen as a mandatory component by various hospital administrators. So at the University College of Medical Sciences, we have developed an ABCD paradigm, which is basically for medical students, and it states that we need to develop analytical attitude, ethical and professional behavior, how to make effective communication, to respect diversity, and to be empathetic. I'll be using the same ABCD components to talk about disability awareness in today's talk. The first thing which comes to the mind is we all have our own individual perceptions about disability and people with disability. Now that amounts to attitudes.
In terms of man days, and depending on the total man.
So that is what we call as attitudes. And our attitudes are generally shaped by what we see around. And many a times, cinema plays a very significant factor in how do we perceive various things and how do we develop our own attitudes. So let's take a very quick example of how cinema portrays the life of people with disabilities. On the screen, you see two Hollywood and a Bollywood films photographs, both of them in which the protagonist was a person who was an able-bodied, but he meets with an accident and he becomes a wheelchair user. But the disappointing message of both of these films was that what a paraplegic person wants is only to die by suicide. And the people who are sitting in the auditorium, when they leave the hall, they are leaving with this disappointing message that perhaps people with disabilities are the burden on society. So let's see some examples of real people who have acquired disability. On the screen, we have Major D.P. Singh, who during the Kargil war developed a disability by which his leg had to be amputated. And it was a great struggle by the hospital staff to save him, but ultimately he was saved. Now, Dr. Major D.P. Singh never think about dying by suicide. On the contrary, what he did was unthinkable. He is India's first blade runner. He runs marathon on his carbon fiber prosthesis. And unfortunately, no film has been made on his journey so far. Similarly, another example of a national volleyball player who was going to Delhi when in the train, some hoodlums, snatched her bag, because of which she was thrown out of the moving train. And she fell onto the railway tracks, and there was another train coming from the opposite side, because of which one of her leg had to be crushed and had to be amputated. Arunima Sinha also grappled with this problem in the hospital at All India Institute of Medical Sciences, that what will happen to her dream of becoming a national volleyball champion. And of course, Arunima Sinha did what is unthinkable by majority of us. What she did was, she became the first woman in the entire world who climbed the Mount Everest on a prosthetic limb. And of course, no Bollywood or Hollywood filmmaker will highlight these experiences of people who acquire disabilities. When we are born, we cannot see, we cannot walk, we cannot hear, we cannot talk. In a way, you can say we are born disabled. The same thing happens towards the fag end of the life, where our eyesight diminishes, our movement diminishes, our hearing power diminishes. In between the extremes of this life cycle, we have in the middle period where a woman can become pregnant and they can face various barriers in the infrastructure. Similarly, anybody of us can have a fracture or an injury and they can become temporarily able-bodied. In a way, we all are, in fact, temporarily able-bodied. So we can say that disability is perhaps a form of diversity. And we, the people with disabilities, are the world's largest minority, of which, in fact, anyone can become part of any time. The road traffic accidents are increasing. India is known as a diabetic capital of the world, in which there can be, a gangrene of foot can lead to become a person with a disability as either a locomotor disabled or a diabetic person losing his eyesight because of diabetic retinopathy. In fact, the most recently, on 3rd December 2022, the World Health Organization came up with its most recent flagship global report on health equity for persons with disabilities. And they say that 1 among 6 of us experience some form of disability. And in elderly people, this number is 1 among 3. Undoubtedly, that makes us, the people with disability, as the world's largest minority. But still, 10 years ago, when the WHO first published its World Report on Disability in 2011, they said that disabled people are 2 times more likely to find doctor skills inadequate, 3 times more likely to be denied health care, and 4 times most likely to be treated badly in the health system. Now, after 10 years, again, last year, the WHO came up with that global report. And what they now say is that persons with a disability face greater health inequities, and there is every chance that we, and when I say we, I express myself to be part of the disability community, that we are more likely to die 20 years earlier than non-disabled people. And that shows you the higher disparity among the people with disabilities. So we all have our own individual biases, but when they are reflected in behavior, that's when it becomes problematic. Now, the United States of America is still a country where there is a lot of awareness on disability issues. And this was the most recent survey which was being done on the practicing physician, what are their perceptions about disability in 2021. And a majority, 82%, believe that disabled patients, they have a worse quality of life. Only 41% people were confident, the practicing physician, that they can provide same quality of care to disabled people than to non-disabled people. And just 56% strongly agreed that they can welcome patients with disability into their practices. Similarly, there was another study which highlighted that even the practicing physicians have very poor understanding of their legal responsibilities. And that is also true for us in India. Also, we have in fact 3 legislations on disability. But how many of the people knows about that? That is an important thing to know. And perhaps the root cause of all of this comes from what are we being taught in our medical curriculum. This is a picture which shows you that there are identical mirror images of 2 birds. Both are identical, but there are stark differences. Both of them are looking in opposite directions. And you can see both of them are sitting on different pedestals, one on a higher pedestal and another one on a lower pedestal. Now, this is what we call as the medical versus the social model of disability. The medical model of disability states that disabled people are part of the problem and their disability needs to be quote unquote fixed. So they says, and that's why majority of the doctors who read this medical model of disability in our textbooks perhaps believe that their main job is to fix this impairment. On the contrary, the social model of disability says that the disability does not lie in the individual, rather it lies in the environment. How is it so? This slide shows you 2 examples from 2 different parts of the world, one developing country, another developing nation, one in the United Kingdom, second in the India. One where a wheelchair user is sidelined on a corner, whereas other of our peers are sitting on their desktop with their laptop and food particles, but she has been sidelined in the corner because the lecture theater is not accessible. Similarly, in India, a student with disability who wants to find cure for the disability which he is having, but unfortunately, despite clearing the NEET UG examinations, this is how he goes into his medical school every day, being lifted on steps by his father and brother. And that's why when I say that the barrier lies outside the environment, is that when there is a person on a wheelchair, if there are no ramps, you're making that person with locomotor impairment as locomotor disabled. Similarly, it is very difficult for all of you to read what is there on the slide. And if you remove your spectacles, it is next to impossible to read it. So I hold the power to make you visually impaired, isn't it? If I decrease the font and increase the font, I have the power to make your experience inaccessible or not. So when there are no ramps, people find the infrastructure inaccessible, they become disabled. Similarly, when there are no literature in Braille or accessible format, people with visual impairment becomes visually disabled. Similarly, people with hearing impairment, when there are no sign language interpreter, they become deaf people. But the most difficult of the barriers are the attitudinal barriers. And when you talk about accessibility, already based on my petition, Medical Council of India has issued letters to all the principals that it is their responsibility to make their campuses accessible. In fact, it is very disheartening to know that the place which should have been the most accessible of all, the hospital, they're not accessible. And now we have a legal mandate also, because the Rights of Persons with Disabilities Act 2016 says that no establishment shall be granted permission to build any structure if it does not comply to the accessibility. Moreover, there has been a deadline that by which all existing public buildings needs to be made accessible, be it public or private. Unfortunately, though we have an Accessible India campaign, that deadline has gone. The deadline to make all hospitals, places, cinema halls accessible was 15th of June 2022. But now it gives the reason and chance to disabled people to file cases in the courts, because now the deadline has been gone and there shouldn't be any excuse why these public places are not accessible. In fact, none of the hospitals in India are accessible. The one which is closer to accessibility, the most closer to accessibility, is the Indian Spinal Injury Center. Why is it so? The reason is that who built this hospital? The hospital was built by Major HPS Ahluwalia, who himself is a wheelchair user. And that's why he understands the need that the place which should have been more accessible needs to be disabled friendly. So the disability is not at all a problem, as we have seen now. The accessibility is the problem. The photograph on the slide shows you what could be an accessible reception. If you notice that, there is a lower side for wheelchair users, persons to interact with the receptionist. And also there should have been such a space, it should not be completely covered, that wheelchair users can place their legs behind the counter. Similarly, information needs to be in Braille, as well as there should be adequate signages in broad language also for people who are having low vision. Many places we see that people are shy of making disabled friendly toilets. They say that they need to create one more toilet. There is a men's toilet, there is a women's toilet, then there is a toilet for disabled persons, and there is a toilet for transgender persons. Now, this is what an accessible toilet looks like. Is it an extraordinary thing? It is not. It only have features which will help not only disabled people, but also somebody who is an elderly person, also somebody who is a pregnant woman, also someone who is a toddler, also someone who is short in height. At most of the places, what we see is that the door of the in toilets, they open inside, which prevent somebody who is a wheelchair user to go inside and close the door. Accessible toilets always open into inside, but how many of our hospitals have these facilities? Can we expect that somebody who is a wheelchair user can go independently to use the washroom which is available? Perhaps not. These are some designs of accessible restrooms, and you will see that these are not at all, this is not some very difficult thinking, very simple thing to do. You only need movable grab bars. And when we're talking about gender non-binary people also, or transgender people also, it makes all the more reasons to have an accessible unisex or gender neutral washroom. Because you can see that, that can be used by somebody who is a child, or somebody who is a deaf person because of the height. So rather than having a men's toilet, a women's toilet, a disabled toilet, a transgender toilet, why not we are talking about a universal designed, gender neutral, accessible washroom? Photograph 1 shows you a very smashing, slippery granite ramp, but there is no hand railing, a very poor design. Number 2 is one which is common everywhere. There are steps, but no hand railings. But another thing which is missing is that there are no contrast strips for somebody who is having a low vision. Picture 3 is the one where you will see both hand railings as well as color contrast strips for low vision people to navigate. Picture 4 is where you will see granite things and rugged surfaces, which is not conducive for wheelchair users because people have to push the wheelchair. The last image is very commonly seen, where I don't know whose idea is there, but people are very fancy of putting flower pots just next to the hand railing, making it next to impossible for elderly persons or somebody who are ambulatory disabled to take the help of a railing. This is an example of accessible examination room. How many times have you actually asked for the weighing measurement of a wheelchair user? Because we do not have weighing machines to measure their weight. And this is a basic parameter which we are flouting. We need to have a weighing machine which is accessible for wheelchair user. The blood pressure can be mounted on the wall. There has to be ample clear space so that they can lie on an adjustable examination table, because their height can be adjusted. Now, these are not difficult tasks, very things which are very much doable, but we find that these are non-existent. There are many places you will see people say, quote unquote, handicap parking. I'll come to that language part later on. But I think the best possible thing to use is that you call it an accessible parking for people with disabilities. Please pay attention to the logo. The one showing on a bigger screen is the one which is at my hospital, medical college, UCMS. If you look at the wheelchair user, this is an active image in contrast to the other one where it looks like a wooden chair or a table. The important thing is that this accessible parking needs to be as close to the entrance as possible. And as per the guidelines, it has to be within a maximum distance of 30 meters. But what you will see is that many times this is quite far from the main entrance. Then for visually impaired people, we have braille tactile pathways. But please see an example that, on the braille tactile path, you will see the opening of a gutter. All the recipe for a disaster. And even if people who are using cane, they are walking on their, tactile path, suddenly out of the blue, you will see, that a hoarding is there, which can hit their head. Common things like, for example, taps. The two images which are seen on the slide, they are not friendly for somebody who is having rheumatoid arthritis or elderly people, or who is having trouble with, dexterity, or somebody who is a person affected by leprosy. So these are not the ones which are to be used. These are the designs which can be used. For example, they are not depending upon forceful closure. These can be, you can just move the tap on the side and they can be open. So these are actually examples of universal design, which will not only help only people with disability, but even other people also, elderly people also, those who are having impairments as well. On the tactile path, there are two different types of tiles. One is a guiding path, and then you can see the one which is showing as a square is the one which is used as a warning block for people with visual disability to stop that now you have to change your side. And at many places, we are missing, the curb gradient. At many places, what we see is slope in the name of ramp. An ideal ramp is one which has a gradient of 1:12, but which is missing. So these were the talks about physical accessibility. But again, many visually disabled people can use internet very effectively. And for them, what we need to have is that, and your website needs to be accessible. Here is a common example of the website of Ministry of Health and Family Welfare. There are tools available freely on the internet, like the Web Accessibility Evaluation Tool, WAVE. If you put the hyperlink of any website, that will show you what are the various errors on that websites. So for example, on the MOHFW website, you can see there are 9 errors, 514 alerts. There are 9 contrast features which needs attention, 52 structural elements which are not conducive for those with visual disability. So these are minor things which we need to take care of. Another common thing is that, for example, when you are having your OPD registration online, and many a times you ask image capture. Blind people can take out the printouts from the web, but if you're putting only an image capture, a blind person's screen reader will not be able to use it. So that is why you need to have OTP capture, which is more conducive for them, because with the help of screen reader, they can access that number on their mobiles. Small things which are there. And there was a reason why in the Delhi High Court, I had to file this petition to make image capture out of the picture so that visually impaired can also use the internet effectively. We talked about attitude, we talked about behavior. The third thing is communication, how to communicate effectively with people with disabilities so they are not hurt. There are various euphemisms which are being used for disabled people. For example, specially abled, differently abled, Divyang, and other things. Now, no two individuals under the sun are identically same. Even two identical twins are not same. So why is it that only people with disability have to be given this tag of differently abled? When you're talking about differences or these things, what you are doing is that you are excluding people, whereas we are talking about an era which should be an era of inclusion. So the most important thing is when you're addressing people with disabilities or patient with disabilities, the standard form is please use person's first language. They are persons first. For example, person with visual disability. Having said that, at many places, disabled people themselves prefer identity first language, just to highlight that there are the barriers in the society which makes them disabled. So they prefer using, for example, a blind doctor, a blind artist, an autistic chess player, words like this. So this is to respect their identity. That is also a correct way. Third thing is we are very shy of using the word disabled. Now, disability does not mean inability. We should normalize the use of the word disabled. Even if, the light goes off, the internet is off, what you will say is that internet disabled. Suddenly the light comes and you again say that internet is connected. So that means the barrier lies outside in the environment, not in the individual. So disability does not mean inability, and it is perfectly all right to use the word person with disability. Try to avoid words like crip, words like handicapped, words like specially abled, differently able. Now, we have again given a new name by the name of Divyang, but the reasons why people with disability, our community is a little bit against the word is that for the same reason by which Dalit community rejected the use of the word Harijan. Now, Harijan also means Hari Ke Jan, people of the God. But the reason was that this word was not given by somebody from a Dalit community. It was a label imposed on them by somebody from a higher caste. And that is why when you are calling an individual, it is fine. But when you are naming an entire community, you are labeling them, it is all the more important to ask them first, what do you like? That name should come from that community who you are being labeling. And there is the same logic by which disability sector is against not very comfortable by using the word Divyang. Moreover, the word divine means that we have some sort of a divine powers. Now, I am a average medical doctor. I do not have any divine interventions or divine powers. I'm just a person with disability. Recently, the Mumbai High Court, they have scolded few doctors who have used the word quote unquote retardation. That is why it is very important that we use the right terminology. For example, we can, the correct wording for persons is persons with intellectual disability or persons with psychosocial disability. So it is important to know that the words which are hurting, to remove them. For example, when the President Obama, he became the president in the United States, the first thing which he did was that he removed the N word from wherever it was. So that is why it is important to view people as human beings and respect their choices. Moreover, we have a new act now in 2016, where even if you are indirectly humiliating or insulting a person with a disability, that can attract penalty as per law. And there are both financial penalty as well as person can be imprisoned also under section 91 and 92. So it is very important that we are using the right terminology in our normal discourse. We talked about need to change attitudes, need to change behaviors, need to make effective communication. The second thing is respect for diversity. How often we have seen that there are photo ops where the politicians come and they distribute wheelchairs. Now, all people with disability come in different sizes and shapes. And not one single wheelchair will be suited for all of their needs. We have seen on an adult wheelchair, politicians take photo op and they, they set two children on their wheelchairs. Now, I'm a part of World Health Organization's wheelchair provisions guidelines, which will be released in this April. And the first question which we had during our 2-year-long discussions was that how many countries are actually using wheelchair prescription? I haven't heard that word in major hospitals. So nobody knows how to prescribe wheelchairs or how to prescribe assistive devices for people with disabilities. Similarly, many times we are doing such actions which defy the dignity of individuals with psychosocial disabilities. Whether it is a person who is of unsound mind, it is our right, it is basic human right to protect their dignity. And we have seen what happened during the Irrawaddy tragedy, where there were people with psychosocial disability who were chained in a dargah, and because of a fire, they could not run, and 35 people had to die. They were burnt alive in 2001. I remember my medical college days when I went for disability certification, and there were 3 medical doctors, 2 higher up senior officials, who find it non-objectionable that, they asked me to remove my trouser and affix a photograph showing my deformed limbs on the disability certificate. Now, nobody find it, objectionable that what they are doing is that they are compromising the autonomy and dignity of a person, and that to a medical student of their own medical college. And this practice was prevalent for a very long time. Ultimately, I have to file this complaint in the Court of Chief Commissioner for Disability. Now they have asked to stop using photograph of your deformed limbs in your disability certificates. But again, the question is that of, the paternalistic medical model of disability, where, doctors are fine that, there are patients in front of them and they are happy to sign on the certificate which shows their deformed limbs. It is all the more important to know the legislations because very recently, 3 years ago in a case, in fact, one of the metropolitan judge, they asked a senior citizen that, please take him to a mental hospital and do his mental examination. And we have now a Mental Health Care Act in 2019. This process was completely illegal. But the Delhi High Court intervened into this one, and in fact, they have instructed that metropolitan judge who gave this order, the police officials who took that senior citizen against his wishes to a mental asylum, and the doctors, the psychiatrists who actually keep this senior citizen for 7 days in the hospital without his informed consent, all had to undergo an orientation course in Mental Health Care Act. So being an administrators and hospital administrators are very, it is very important. It is pertinent to know what are the legal basis of various laws, because law is black and white. If you are on the wrong side of the law, you are on the wrong side of the law. Attitude, behavior, communication, diversity. The last thing is empathy. At times, even doctors can be empathetic. There was a medical student who has done MBBS. After that, he applied for NEET PG. And the doctors in one institution claimed that he cannot pursue post-graduation. Similarly, there was another doctor who was doing urology, and he, because of some accident, become paraplegic. Now he uses standing wheelchairs and performs urological operations on a standing wheelchair. But the problem is that when this person will apply for a faculty position or a job anywhere in India, he will not be allowed because someone has prepared the guidelines that somebody on a wheelchair cannot gain employment if both of the legs are involved. On the contrary, the same person who is here, he is performing these neurosurgical operations now in Colombia. He's doing his fellowship in neurological processes. So what I'm trying to highlight is that many a times the policies are being made by non-disabled persons without involving people with disabilities. And they, because they have no lived experience of this disability, they assume what a person with a disability or a doctor with a disability can or cannot do. How does a doctor look like? The photographs which are here shows all of the persons are blind doctors. Dr. Hartman, a pharmacologist from India, another one who uses a guided dog, a psychiatrist who passed out from NIMHANS, now is a faculty member in an institution of national importance, and a deaf-blind. The student is both deaf as well as blind, a deaf-blind student in the United Kingdoms. And the emeritus chair of ophthalmology, he has said about these people, a few of them who graduated from his institution, that not only do these gifted disabled physicians, blind doctors, benefit medicine, sciences, and their patients, but their classmates learn lesson from them. They gain empathy for people with disability and learn a lesson in courage. Unfortunately, despite having examples of blind physicians in India, majority of the INIs, when they release their advertisements for recruitment, they have not identified the post which are, for example, in psychiatry, the post being suitable for visually impaired. Similarly, the post in urology being suitable for somebody who is have a locomotor disability, despite the two examples which I have showed you. Now, in the law, there is a term reasonable accommodations, which is necessary and appropriate modification and adjustment without imposing a disproportionate burden to ensure that disabled people enjoy or exercise rights equally on an equal basis with others. For example, if there is a blind psychiatrist, if you provide them a tablet with a screen reader, he would be happy to complete his work. Flexibility of timing. The pandemic came. Before the pandemic, the disabled people were asking for, work from home, and nobody was giving us the chance. In came the pandemic, everybody was working from home. Was that so difficult to use the reasonable accommodations for disabled people? Giving flexible time so that they can work as per their needs. Giving them accessible facilities, for example, accessible infrastructure. Modifying the work sites based on their disabilities. These all are examples of reasonable accommodations. There are a few more things in our law which every administrator must know, and these are that clause of non-discrimination. The second is every establishment, be it a government body, they need to publish an equal opportunity policy. How many of the hospitals, or how many of your institution or hospitals, have an equal opportunity policy which is there on its website? Now, this policy was to be sent to the Chief Commissioner for Persons with Disability if you are under a central government hospital, or to the State Commissioner if you fall under state government, and to be uploaded prominently on their website. Only few hospitals have done so. Appointment of a grievance redressal officer, that if any employee with disability has a problem, they need to act on that in accordance with Section 23. And there need to be a person with disability in that committee when we are taking action on that committees. So a few questions for all the hospital administrators. Does your hospital respect the disability legislations and provisions? I showed you many examples of universal accessibility. Does your hospital provide universal accessibility? Third important thing, how many employees with disabilities are there in your hospital? How many of them, these are in leadership positions or involved in policy making? When you make policy for patients with disabilities, do you involve them in these decisions? Are you strengthening human rights? Is your hospital strengthening inclusion or exclusion? The examples which I highlighted were showing you the difference between the charity-based approach and the human rights approach. Making infrastructure accessible was optional earlier, but not now. It is a mandatory, obligatory requirement under law. You can be sued if you're not making your premises accessible. I shared with you the stories, examples of paternalistic attitude in a doctor-patient relationship, compromising the autonomy of patients with disabilities, disempowering them, focusing more on fixing the weakness, the bones, the body parts, rather than fixing their own environment, which is largely inaccessible. Facilitating the activities by the form of giving assistive devices, rather limiting the activities. The reason why people do not like wheelchair is that wheelchair are sometimes used to transfer patients. And because of that, people assume that it is a sign of weakness. I would like to correct people here. A wheelchair is a sign of empowerment and mobility and not weakness. We need to stop discrimination and promote equity. We need to stop segregation, exclusion, and talk about integration and inclusion. Finally, in my last slide, I would like to tell you that disability is diversity and disability is not inability. In fact, the most recent WHO report in 2022, the report on equity for persons with disabilities, says that if you invest $1 on disability inclusive infrastructure, you will get $10 in return. So in fact, it is a big investment purposes. So what we need is that we need to change our attitudes. We need to change our behavior. We need to make effective communication respecting the diversity of blind people, deaf people, autistic people. We need to respect for diversity, not only for disabled people, but for other marginalized community as well, like transgender community and other socioeconomic strata community, homeless people, people with psychosocial disabilities. And most important of all, being doctors and administrators of hospitals, we need to be empathetic, which means that in whatever decisions we are taking for disabled people, we need to involve them, because nothing about us without us. Thank you so much.
Thank you, Dr. Satendra, for such a wonderful, insightful, and I must say, thought-provoking talk. And I'm sure that many of our members will get motivated with what you have shared and will revisit their own facilities to see how accessible these facilities are. So thank you very much, and I'm happy that we invited you for this discussion. Before I open for the questions, and I don't see any questions, at least in the chat box, if the President, sir, or the Executive Director, ma'am, wants to say something before we open for the question.
Yeah, I would like to, first of all, thank you, Dr. Mahesh Devnani. You have arranged an excellent webinar, and I am especially thankful to Professor Satendra Singh for his excellent presentation. I mean, I was thinking, disability compliances, he will be talking about only the compliances. But he has made us, he has given a lot of wisdom as hospital administrator, and has actually made us aware that how the health facilities are to be, designed. It's really surprising that 1.3 billion people have significant disability, and they're the largest minority. And it's more surprising that even the 4 times they're likely to get badly treated in the health facilities. That means there's very less of awareness on the disability. And he was telling us that even 82% of them don't get the quality care, which is again a matter of great concern. And above all, we don't have empathy to treat them. That's really surprising. And there is a requirement. Definitely, there is a requirement in change in the policies, and they should get equal opportunity in the healthcare institutions. I'm really very happy and very thrilled to listen to him, and the way he has presented how to make the hospitals compliant with the make accessible to such people. Dr. Satendra Singh, sir, we're really happy, and we're really grateful to you that you have given a wonderful talk. We thank you very much, and hope to listen you more often. Thank you very much.
Thank you so much, sir.
Thank you, sir. Dr. Shama, would you like to?
Yeah, actually, thank you from the core of my heart, sir, for such a wonderful presentation. I think what you are talking about is not disability of people. It is disability of the community at large, not to be able to see how inhuman we have become over the years. And there is a lot of need, not just to whatever we are seeing is something that any one of us can encounter at any time of our lives. And it has got more need to talk about being more human. I think we have, as humans, lost the compassion of being a human. So I think the front that you have picked up has to go at a very different level, where we have to actually touch base from the spiritual level of being a human per se. I remember when you were speaking, I also remembered one more thing. I think, sir, you would have also noted this. During the COVID period, many of them took pets at home, okay, because they had nothing much to do at home, so they took pets at home. And after COVID time, believe me, sir, I was taken aback to see those pets were left alone on the roads, not being cared for. How can somebody be so human to another soul, I would say, another life form? It is talking about an issue as large as that. And I think at least in a country like India, which is so diverse, with so much heterogeneity in population, so many religious faiths sitting together, I think we should be the one who should set a trend, how to look at these things holistically. And I think we are the one who can actually set, and these won't come just by discipline. It will come by the ability to be able to feel other person's uh, um, pains when you have your own pain. I think those are something that we need to bring on to the platform. And I kudos to you, sir, for taking this initiative at such a national level. I would be very happy if you can share the presentation. We would like to leave it on our website, because people should see this presentation. And also, I remember when you were saying, I would remembered Stephen Hawkins, Dr. Stephen Hawkins. The man lost everything by and by over the period of time, but gave time theory to the world. I mean, what more should we say? It's all that, it's all there in our mind, sir. We are disabled in our mind, sir. I think the ability has to start from there. Then everything else will become so easy. And thank you so much, sir. Thank you very much.
Thank you, Dr. Sharma. In fact, in 2001, Stephen Hawking came to India,
Yes.
to Delhi. And that time, after meeting the various officials giving lectures, he expressed his desire that tomorrow I would like to see Qutub Minar, Lal Killa, and the different forts.
Okay.
And it opened a Pandora's box because it was 2000 and he was a wheelchair user, of course.
Yeah.
So, it was a nightmarish time for the Ministry of Social Justice and Empowerment. But would you believe that in just one night, they used temporary wooden planks to make the Qutub Minar and the Lal Killa places accessible? So somebody, for a foreign person, in just one night, when they can make the premises accessible, what is stopping them to work for citizens of India? Which, even in 2023, majority of the places are not accessible. And in fact, who was the voice of Dr. Stephen Hawking? Who he used to, speak to the people through his, computer screen. So an Indian has made the software by which he could speak to the world. So an Indian has designed that software.
That's precisely what I'm saying, sir. We work very well in emergency. I really believe that our people are very innovative. Jo jugaad word hai na, sir, that works very well for us. We know how to make things easy. We have done most innovations. But the point is, we are not thinking. And the day we start thinking, आप बोलो ना sir, पूरा demonetization overnight हो गया, किसी को पता ही नहीं लगा. At a national level, हम स्वच्छ भारत मिशन बोलते रह गए. ओवरनाइट प्रधानमंत्री स्कीम में से सबको बोला कि तुमने टॉयलेट्स बनाओ जी, तो सबने बना दिया. So the point is, the India as a country can actually make a huge difference. The point is, sir, बोलना नहीं चाहिए, जिसको चुभना चाहिए ना, उसको एक बार चुभना चाहिए, तभी वो change होगा, sir.
Thank you, ma'am. And I see 3 hands, so I want to give opportunity to them. First hand is Dr. Paramans Mishra. Dr. Mishra, go ahead.
Thank you, Dr. Devnani, for arranging this excellent talk. And Dr. Satendra, it's a pleasure to hear such a nice talk from you. I am from UCMS 87 batch, so it is a pleasure to have you on board. And I have worked with the Spinal Injury Hospital for 10 years as a medical superintendent and CMA. I have seen the place, so it is really nice. I was associated with Society for Disability also for a long time. So I have seen lots of changes being made in different hospitals, and spinal injury, of course, as you said, is most disabled friendly hospital. So I wanted to know what is to be done in a hospital for visually impaired people, because physically we know we can do many things, but what is to be done for visually impaired people so that they gain free access or comfortable access to the hospital?
Thank you so much, Dr. Mishra, and glad to know that UCMS connection as well. So answering your question, sir, of course, people with visual disability, what they basically need is that usually they are independent because they use their white cane, but still just to make life more easier for them, we need to have those tactile pathways. Already Ministry of Urban Design, MOUD, they have given the universal design guidelines. So earlier there was a confusion which guidelines to follow. Should we follow the CPWD guideline? Should we follow the Commission on Disability guideline? But now there is no ambiguity. The Disability Act very clearly says that you need to follow the harmonized guideline, that is black and white. So there is no confusion between the architectures as well as the Public Works Department people. So what is needed is that basically tactile pathways which should be there. In the lift also, then the signages should be in braille so they can understand that which button to use them. In addition to that, second thing is that now with the advent of technology, not many people prefer using braille, because now everybody has more or less phone with them, and there are a lot of screen readers which are available free of cost in the mobiles also. So that is how they can communicate, and very effectively using mobiles as well as computers also. So rather than more, we should focus on making the websites accessible to them. So already in the Disability Act also, they have mandated that all the website must comply to the international GIGA standards, where you can see that you can increase the font, you can increase the contrasting color on the backdrop, you can avoid flashes, for example, yellow colors, which is often seen on websites like big and new, because at times they can also induce epilepsy also in the patients, all that. These are small steps which are there by which you can make your websites accessible. And regarding the physical infrastructure, you can have those tactile pathways, as well as for people who are having low vision, you can have those contrasting strips on the steps wherever they are, on the staircases. So these are the things which are low-hanging fruits which can be done very effectively.
Thank you.
Thank you, Dr. Satendra. And I have shared the link of harmonized guidelines which were issued in 2021. Next, I see Dr. R.K. Patni.
Thank you, Mahesh, for organizing this, and I join the rest of the people in saluting the speaker. Excellent talk. 2-3 things that I would like to share here. One is, most of us are not sensitized enough. People would like to do much more, but most of us are not sensitized enough, nor are they aware of the difficulties being faced by the disabled. Now, speaking from personal experience, I'll just give 2 quick examples. In the medical field for the last 3.5 decades, 35 years. And recently, about 6 months back, my mother had a fall, hip fracture, and I had to navigate the hospitals, different corporate hospitals, the best. And I found it so difficult. So it was the first time I experienced it firsthand, and I got sensitized to it. The second one I would like to share is about 10 years back. For the first time when I went to US, I had traveled in Europe, I had traveled Middle East and other places. Went to US, obligatory trip with the kids to Disneyland. And I found lots of people with disability over there. My first thought, it was my first visit to US. My first thought was, oh, US has so many people who are disabled. But then, when I started rationalizing, I said, this is awesome. They have made an amusement park also accessible to those with disabilities, which was an amazing experience. I came back with that, and wherever I go, I share this experience with them, that even an amusement park can be made accessible. All those rides in the amusement park, all the roller coasters were made accessible to most of the people with disability. And here we are talking of basic things, even in a hospital. So sensitization, yes. Education, yes. Personal experience, there's nothing better than personal experience to understand it. Once again, thank you very much, and my compliments. I wish you more.
Dr. Patni, in fact, the example which you shared was my same reflection when I went to London for the very first time. And because that was entirely different world, both London and the Chicago, USA. Because I could walk on any pedestrian without any help. And people on motorized wheelchairs were, going here and there and everything. I wondered, what I will do in these places, because, there are no problems in disability essay. Moreover, but the laws are very strong over there. I mean, the same people in India, you will not find a parking space for disabled persons. But when the same people travel to US, they follow all the laws very stringently and diligently. So that is the basic difference about mindsets. But until this comparison, of course, people will not realize. They will. I used to believe that the first right on a road is that of a car driver. That notion only changed when I visited US. That no, it is a right of a pedestrian user. The first right is that of a pedestrian user. Only when I saw the comparison in the US.
Yeah. On disabled parking, just another 20 seconds. I do go around for various accreditation assessments. So a recent visit to a hospital, I asked them, where is your disabled parking? And they showed me a beautiful board, disabled parking. And obviously it had been put up just 2 days before our assessment. But the cars parked, there was not one, there were 2 cars parked in that single disabled parking, and they both belong to the senior hierarchy of the hospital, not to those in need. Right?
that needs to change even in the government setups also. So thank you, Dr. Patni. Now I see the hand of Dr. Rajiv Kumar Jain. Sir, please go ahead.
Yeah, thank you, Dr. Mahesh, for organizing this wonderful webinar. And Dr. Satendra, you have brought in such an important issue to the fore. One good thing that has happened over the last, I would say, 30 years is a transformational change in attitudes of not only the people, but also the people who use these facilities. Whether I'm talking in the context of public facilities, whether it is metro or railway stations or airports or schools, or for that matter, many of the public buildings that have come up now. One big transformational change which has happened in the last 10 years is significantly the change that metro has brought about. Metro, for the first time, brought in all the nuances of design and construction in their execution of the metros. But what is happening is the person does not land directly in the metro systems. He has to navigate through the roads and lanes and bylanes of the city as well. So that definitely is a challenge. Urban design, India has seen big transformation, but a lot need to be done. But no doubt, transformation has occurred, which is very significant, and especially in terms of people's attitude towards people who are specially abled. That you would agree with me in this view. We tend to always, look up to the Western countries that they have done so much, but Western countries also have a long history of these transformations. It does not happen in a day. And India, it's like retrofitting a building for quake-prone buildings, quake-prone areas. So I feel one should welcome. And the most significant change that you must have observed, Dr. Satendra, is the change in the definition of the so-called disabilities. Now the act is much more wider. Our own understanding is now more refined. And you rightly mentioned the so-called three major, people feel that only orthopedically handicapped, visually handicapped, or hearing handicapped is and the entire gamut. But people forget, and especially after Tare Zameen Par, people started actually realizing that there could be more. So from that context, I feel what you have actually discussed in terms of the design and interventions and in terms of consensus statement, it is a great, I'd say, journey that India has traveled. Only thing is now it has to travel deeper into, I would say, cities and small towns, but that is happening, and that's a great change. Thank you for taking out your time, Dr. Satendra.
Thank you, Dr. Jain. I agree with you. And one of the reasons why this change has come up is because of the advent of, internet. Because now people are talking about this on social media, right? For example, Dr. Patni also said that, I have not seen so many disabled earlier in the US. The reason for that is that when was the next time any of you saw a wheelchair user person in the movie which you saw last time? Have you ever seen it? The reason is that people want to go outside. I'm a big cricket fan, so I had to go to the PL route to make the Firoz Kotla stadium disabled friendly to watch, make the hill be accessible to watch IPL matches. So the reason for that is now people are posting about their bad experiences, so there is an awareness created. But two good example which you gave is that metro example. India has made one of the beautiful metros in India, but 80% of disabled people in India, they live in the rural areas. And the only mode of connectivity there is Indian Railways. What is stopping Indian Railways to make, their various compartments disabled friendly? We still see that in Indian Railways, there is a huge gap, and there is all the more dangerous reason for a person to fall in the crack. When we can make, metros, why can't we make Indian Railways accessible? Even the Vande Bharat only has one compartment which is disabled friendly. What about the other compartments? They're not. The only time there was a ramp made was when the former president of India traveled with Indian Railway, and there was a red carpet, ramp for them. So still there is a long way to make all of these things, but that only can create with, when our allies, not only disability community, but other people also come forward, bureaucrats, administrators, they talk about these issues right from the beginning, that they are making a new hospital, let it make it, the infrastructure accessible right from the beginning. So thank you for sharing that point, sir.
Thank you, Dr. Jain. The one more hand I see is Mr. Satpal. Please go ahead. Mr. Satpal, are you there? If not, then I think before I just give my concluding remarks, I think there is a
there is a comment also by
question or two on the
I'll very quickly address that the comment states that in the hospital there are multiple places, so very often they make only one place accessible.
Yeah.
Other places are usually locked. So that is common thing which I have seen. Even the auditoriums only, many times people have invited me for a talk and there is a backdoor entry. There is the speaker comes from the backdoor entry because their stage is not accessible. On the contrary, what are the places which are accessible? Now you see emergency entrance. There is a slope over there. The same place is also used for transferring substances, the heavy items which are there. So when you are making a ramp, you are not only helping disabled people, elderly people, but also you can ferry your heavy instruments from there, and you can help other people also. So there is a more a benefit in making the places accessible, because if a wheelchair user can use your entrance, almost everybody can use that. So we need to think from that design, that we should talk about universal design, which is helping not only disabled people but all the people. So there's a merit in making all places accessible.
So I take one last question that's on the board.
Yes, sir.
Yeah, please go ahead.
Yes, sir. Sir, I am very, very thankful to Satendra, sir. And I have been junior to Satendra son during my MD. So I have seen sir fighting for the cause of the disabled person. And I have learned not much, but 10% I am doing the same thing. I have two queries. One query is, when we raise the issue of person with disability, then reaction is there from the authority and all other side. They start targeting by using many ways. We demand ramp, but they give us lots of work for other, which are not directly, indirectly related to you. One thing is this, that we need change in their attitude when we demand our basic need.
And that is what the objective of today's webinar is, that the hospital.
Second is query. I am having query that all the hospital, all the new place, they are having very beautiful shining floors. We can even see our face in that floor. So that is there any criteria that the friction level of that floor to be what, so that we people who are having crutches, I use crutches, I use 2 crutches, so I always having fear of falling on that floor. So is that friction level of that floor is fixed in any document? Because I try, but I failed. So today hope Satendra sir will guide regarding this.
Thank you so much, Dr. Satpal. Very quickly answering your second question first, is that of course if you look at the harmonized guidelines, it talks about having anti-skid tiles. The floor should not be slippery enough. So it is very much mentioned in the guidelines that needs to be done. The first question is very important, and in fact that is the same thing which many people ask me also, कि अब इन लोगों को भी ये चीज चाहिए, disabled लोग हैं कितने दिन को ये चाहिए. So I think the answer to that is that what we have done in the elections में जो हमने बनाए थे सारे polling booth accessible, we used a wider ambit. We said that we need to have ramps not only for voters with disability but also pregnant women as well as senior citizens. Now you need to bring in other factors when you are asking about these demands. Use the example that this will help senior citizens, this will help elderly population, this will help pregnant women, this will help those people who are having chronic illnesses. Then you are including a larger data or subset. So then the people would be more likely to be interested in what you are saying. So all the very best, Dr. Satpal.
Thank you, sir.
So thank you very much, Dr. Satendra. Though we do not have time, do you mind if I ask a question before I wrap up?
Yeah, please, sir.
Yeah, so I just want to know, see, if we have organized this webinar, you came, you delivered this talk, we got motivated, and we will do what. but how to sensitize our own staff, our nurses, our residents, our doctors, towards the needs of people with disabilities? What more can we as administrators do to make them sensitized? We cannot have you all the time in the hospital, right? If I can ask you to come to PGI and deliver a talk, that will be a one-time affair. But what we can do to make people sensitized, our staff more sensitized towards the needs of the people with disabilities?
Yeah, good question. And the answer to that is what happened with me. When I joined my institution, I was assistant professor. My principal suddenly appointed me as the nodal officer of disability. And that's how all the changes started. And the first thing which I did was that I made a committee having students with disabilities, non-teaching staff with disability, and faculty member with disability. And then I got to know that the the hostel area is not accessible, and it was made accessible. So the first thing is that, there is a mandatory requirement. You need to have a grievance redressal officer, make that an employee with disability, or appoint a nodal officer with disability, somebody who is a person with disability himself. Put the focus on that person, that it is his job now to organize those trainings, because he has a lived experience. So he would be more forthcoming, and he would be happy to sensitize the nurses, the paramedical staff, and all of that thing. So that is, I think, the first thing by which you can organize all of these stuffs.
Wonderful, wonderful. So thank you.
Doctor, sorry
Journal on
to interject.
AHA. So that is, of course, it has a very wider reach. So start writing about some editorial commentary pieces on that, so that these things come up into checklist also. Because if these are mandatory inclusion, and for example, the NAC accreditation is there, NABH accreditation is there, so we can start making these things as a important checklist point in those checklists which are available also. So that will.
Sorry to interject here, Mahesh.
Yeah.
I completely agree with your point that how do we make it as a regular practice in our behavior, how to bring in behavior change. I think as AHA, what we should do is, in all our courses, 1 hour or 45-minute session from sir, we should start off from here on.
If he agrees.
If he agrees. If he does not agree, we would request him to depute somebody to speak on his behalf, so that at least we as administrators, we take that one little step from our side. And because we have a lot of people coming in, from there they will take it up, and that transformation that he's talking about, that there will be specific committees in each hospital will happen. That will happen as a next step. We as AHA, let us start taking that step. I would seriously say that, sir. And please share your PPT. I will put it on the website. We'll ensure that it is put on the website. And we will also encourage you. We have a regular blog writing. So Dr. Patni and all are very active on this. If you can write some blogs, we will be very happy to pick it up, sir.
Yeah, Dr. Sharma, we have the PPT. If he permits us, we can, Dr.
Yes.
Please, can put it up if he has no objection on this.
Yeah, no objection, Dr. Devnani. In fact, also, ma'am, what you are saying is that I'm very passionate about these issues. So, my dream came true when I was succeeded in making disability competencies. The same thing which you are asking, that, there should be a 1 hour talk. So we prepared 8 important, competencies which should be there in the new curriculum. Now it is meant in all the curriculum, all the medical colleges in India, disability competencies. So 8 hours are allotted for this, and the same things may be adopted by AHA also. So I'm happy to share all of those literature with all of you.
Fantastic, sir. Thank you so much, sir. Thank you, Dr. Mahesh.
So thank you very much, Dr. Satendra. I cannot emphasize enough how grateful we are for you sparing out the time and sharing your thoughts. I think everyone is motivated. Before we sign off, I just want to tell everyone about the next webinar, which is on the 1st of April, in which we will be discussing self-care for hospital administrators. We care for our facilities, we care for our staff, our patients, the visitors, but many a time we are negligent about our own health, our own mental health, physical health. So next time what we will be doing is we'll be discussing the self-care for hospital administrators, and Professor Ajay Bahal, who is a fantastic human being, I know him personally, he will be discussing it, and Dr. Vijaydeep Siddharth from All India Institute of Medical Sciences will be moderating it. So with that, thank you once again, Dr. Satendra Singh. Thank you all of you participants. Thanks to my AHA staff who works in the background and has done hard work to make it a success. Thanks to my colleagues in the executive board of AHA. Until we meet again next time, take care. Thank you very much.
Thank you. Thank you. Thank you very much.
Thank you.
That's Thank you so much.
Thank you. Thank you. Grateful.